Hello and welcome to Med Tutorials. This is your place for simple and easy to follow tutorials in internal medicine. Today is going to be level 7 in the series titled Decoding the ECG. Today we're going to be dealing with the problem of bradycardia in an ECG. Very often you have patients presenting to the emergency room with bradycardia, and ECG would be your first investigation of choice. And then when you see the ECG, you need to decide, is this sinus bradycardia or is this some form of heart block? In today's tutorial, we'll be looking into these issues. We'll be covering heart blocks. We'll see the various kinds of heart blocks and how you can detect them on an ECG. So let's get started. So in today's session, we're going to have a quick revision of the conduction system of the heart. We're going to look into the concept of the secondary or the escape pacemakers of the heart. We'll look at the different patterns of bradycardia, and once we have done that, we'll have an approach to ECG with bradycardia, and then we'll end by looking at two test ECGs. So the conduction system of the heart. If you want to know details of this conduction system, you can go over to the first level tutorial, and I've put the links in the description box below. So the conduction system of the heart, we know that impulses are generated from the SA node in the right atrium, and from there the impulses pass through the atria and they reach the AV node, and from the AV node they go into the bundle of His and the right and left bundle branches, the Purkinje fibers, and finally they reach the ventricles. Now what happens if the SA node malfunctions or dysfunctions? Then you have secondary pacemakers that come into action. If the SA node is unable to generate impulses for any reason, other areas in the heart will function as pacemakers, and these are known as secondary pacemakers. Now secondary pacemakers usually work as a hierarchy. It's if one level doesn't work, then the other level sets it. For example, if the SA node doesn't work, then the atria usually sets in as pacemaker, and they're able to generate impulses at the rate of 60 to 80 beats per minute. If the atria fails, then the AV node sets in as pacemaker, and they can generate impulses at 35 to 60 beats per minute. And then we go down to the bundle of His, bundle branches, Purkinje fibers. They can generate impulses as 25 to 30 beats per minute. And finally, if all else fails, the ventricles set in as pacemaker with a beat impulse of 20 to 35 beats per minute. Usually at this stage, when all else fails and it's just the ventricles, you have reached the very end of the cardiac activity, and it's not a good sign when you just have an idioventricular rhythm going on. Looking at bradycardia, the causes, we have basically two main pathologies going on. It could either be a failure of impulse generation or a failure of impulse conduction. Sometimes you could have a mixture of both, but these are usually the two main pathophysiological problems that are taking place in bradycardia. And if we understand this, it'll help our approach in some way. Now we're going to talk about patterns of bradycardia that we see on an ECG. This pattern, as we will see, is different from what we'd call as causes of bradycardia, because different causes of bradycardia can manifest in a different pattern in the ECG. So the pattern, again, it depends on the site of the conduction system. For example, if you have a problem with the SA node, you could have sinus bradycardia, or it could be a sinus node dysfunction or a sinus node exit block. We'll be doing this in a little more detail in the coming slides. At the level of atria, we have the problem of wandering pacemaker, or it could be a sinus rhythm with frequently blocked premature atrial complexes. At the AV node, we could have a junctional rhythm that's taking place, or it could be an AV block. That's what we popularly call as a heart block, the second degree and the third degree AV blocks. And at the level of ventricles, we could be having an idioventricular rhythm. Coming to sinus bradycardia, this is probably the most common form of bradycardia that we see in the ECG in day-to-day practice. And what is the problem here is that the sinus node produces impulse, but it is at a lower rate. And this is conducted normally through the heart. So if you were to look at an ECG in sinus bradycardia, the ECG would be normal except for a slow heart rate. So the only abnormality we see with sinus bradycardia is a heart rate that is less than 60 beats per minute. And this is what we commonly witness in clinical scenarios, is that the most common form of bradycardia is sinus bradycardia. Now, looking closely at the SA node, we'll be dealing with this condition of sinus node dysfunction. So when we look closely at the SA node, there are two parts. We have the inner part and the outer part. The inner part consists of the P cells, which produce impulses, and the outer cell is the T cell, which transmits impulses. So the P cells produces the impulses, and the T cells' only function is to transmit these impulses from out of the SA node to the atrial cells. So if you have a dysfunction of the P cells, you're going to have a problem with production of impulses. And this is what we call sinus pause and sinus arrest. These are the two conditions that arise out of P cell dysfunction. If you have problems with the T cell, you're going to have problems with transmission or conduction of these impulses, and that results in sinus exit block. Now, sinus exit block, where the T cells are not functioning as they're supposed to, and they are preventing the conduction of the impulses that are produced by the P cells, we have 3 degrees of sinus exit block. The first degree is just a prolonged conduction through the T cells. So they conduct the impulses, but it's in a prolonged manner, and we can't witness this on a normal ECG. Second degree is an intermittent block of impulses. So intermittently, the sinus impulses produced are blocked. And in third degree sinus exit block, there's a complete block of impulses from the sinus node, from the P cells. If you look at the first ECG, you see after the third complex, there is a gap. There is a gap after the third complex. The RR interval is markedly prolonged after the third complex. If you were to compare it with the second RR interval, it's markedly prolonged, but it's not double, it's just prolonged. And this is what we would classically see in sinus pause, where there's a prolonged RR interval, but it's not exactly double. So what is happening here is the sinus is producing impulses in a dysfunctional manner. If you look at the second ECG, now again you see after the second complex we do see a pause, but here if you notice, the pause is double. That means the RR interval looks to be double that of the first complex. And the reason for this is that the SA node, the P cells are producing impulses, but that third complex which was produced has not been allowed to come out of the sinus node because of a T cell dysfunction. And this is what we would classically call as a SA exit block. And that is a second degree because some of the P waves are transmitted, like the first and second complex, but it's the third one which has been blocked. Now sinus arrest, that is the most severe form of P cell dysfunction, and third degree SA exit block, that is the most severe form of T cell dysfunction, cannot be differentiated on ECG, because in both conditions the P waves are just not formed or seen on the ECG. We come to a condition known as wandering pacemaker now. So this is basically, there's a shifting of the intrinsic pacemaker either within the SA node, that means areas in the SA node, or outside at different atrial sites. So the pacemaker keeps shifting around in the atria and or in sites within the SA node. If you look at the ECG, you would see that the P waves seem to be having different morphologies if you compare the P waves. And these changes in P wave morphology reflect a shifting of the pacemaker site within the atria or within the SA node. There's a condition known as sinus rhythm with frequently blocked PACs. Now, it might not be a very common condition, but it's something that you have to keep an eye out for because it closely resembles sinus bradycardia. So what happens here is that the PACs, premature atrial complexes, are generated just after a sinus rhythm. So if you look at the figure, a sinus impulse has been generated, and just after that an premature atrial complex has been generated. The problem is that the AV node is still refractory from the sinus impulse. The sinus node has just gone, impulse is gone, and the AV node is still refractory. And so because it is refractory, the PAC is not conducted through the AV node. So only the sinus impulse has gone in, the AV node is refractory, and the PAC has not been conducted. So how do we pick this up in an ECG? At first glance of this ECG, it looks like a normal sinus bradycardia. But if you look closely at the T waves, you see that there's a notching of the T waves, and this notching is actually the blocked PAC which is buried in the T wave. So the PAC is generated, P wave is buried in the T wave. Why do we get bradycardia? The bradycardia is due to the pause which comes post PAC. You know, the atrium needs to relax to be ready for the next sinus impulse. So the PAC has sort of set in after the sinus rhythm, and because of the PAC, some of the atrial cells have contracted and they've not yet relaxed for the next sinus impulse to take action, and so we have this pause, and so we have the bradycardia. So in cases of sinus bradycardia, always look at the T wave to see is there any buried PACs which might actually be the cause of the bradycardia. We now come to junctional escape rhythm. Now when the SA node and the atria fail in their role as pacemaker, the AV junction steps in as the secondary pacemaker. So the AV node can generate impulses at the rate of 35 to 60 beats per minute, and because they're generating impulses, these impulses go retrograde into the atria and also forward into the ventricles. Now here's an ECG of junctional escape rhythm. We notice that the P waves are absent. That's because they're buried in the QRS complex. Sometimes you might see retrograde P waves after the QRS complex because it's originating in the AV junction and it goes through the bundle of His and the bundle branches. The QRS complex is narrow. Now we come to AV nodal block, or what we popularly call heart block, because AV nodal block is clinically more significant than what we had seen earlier, the SA nodal exit block. Usually the term which we call as heart blocks in practice refer to AV nodal blocks. Now AV nodal blocks is blockage of atrial impulses at the level of AV node. So the sinus impulses might come right up to the AV node, but then it experiences different levels of block. In first degree AV nodal block, there is prolonged conduction. That means it's just a prolonged conduction through the AV node as compared to normal. And so what we witness on ECG is a prolonged PR interval. In second degree AV block, we see some atrial impulses fail to conduct through the AV node. So it is an intermittent blockages. Some impulses are conducted, some are not. And so under this we have two types of second degree block. First one is Mobitz type 1 or Wenck-Bach, and the second one is Mobitz type 2. We'll see that in the coming slide. And the third degree of AV nodal block is where there is a complete blockage of impulses. Second degree and third degree heart block are the ones which can cause bradycardia, and so we'll look more closely into that. Second degree AV block is of two types. The first one is Mobitz type 1 or Wenck-Bach. Now here there's a progressively increasing PR interval. Why is that? Because the AV node becomes progressively resistant to the conduction of impulses until there is a block at the AV node. And then we see what we see on the ECG is there's a P wave which is not followed by the QRS. To explain that, we look at this ECG. So as you can see, the PR interval is progressively increasing because of progressive resistance to the conduction of impulse through the AV node. And finally we see that the resistance has increased so much so that there is no QRS, no conduction of that P wave in through the AV node. What happens in second degree AV block type 2, Mobitz type 2? Here the PR intervals are all of same duration. And then we see that suddenly there's a block in the conduction through the AV node. So it's not a gradual increase of resistance, but it's just a sudden abrupt block of conduction through the AV node. So if you see the ECG, all three PR intervals are of equal duration, but then suddenly we see that there's a drop of the QRS after the P. That means there's a sudden abrupt stop of conduction after the P wave. Now we come to the final form of AV block, that is third degree AV block, that is sometimes what we call popularly as the complete heart block. So here we have complete blockage of the sinus impulse through the AV node. It's completely blocked. And because of that we see there's independent atrial and ventricular activity. So the SA node might be functional and the atria are beating at their own rate, and the ventricles either through the AV junction or below or from the ventricles they generate their own system of impulses. So the P wave, usually what we know is that the P wave is faster, and because they are faster than the rest of the complexes, when you on an ECG strip we see that they fall all over the place. Now here's an example of an ECG of complete heart block. If you were to see the P waves appear all over the place. There's no proper correlation with the QRS, and they seem to be appearing at different places. And how we notice these P waves for their regularity is, what we can do is either use calipers, or if that's not available you could take a card or a slip of paper and you mark the first few visible P waves, and as you move it forward you will see that these P waves are consistently appearing independent of the QRS complex. Sometimes they're buried in the T wave, sometimes they're buried in the QRS, but as you take this card forward you can see that definitely the P waves and the QRS are independent of each other. And so there you can see how the P waves are going at their rate and the QRS is appearing independent of the P wave. So the atrial rate in this ECG is 75 beats per minute. So that's not the reason for bradycardia, but the ventricular rate which takes place is 37 beats per minute, and that's because these P waves were blocked and the ventricles were paced from elsewhere. That's the reason for the bradycardia. So if you notice this ECG, there's no consistent PR interval because there's no relationship between the P wave and the QRS. The QRS may be narrow if it is spaced from the AV node below the level of the block, or it may be wide if it is spaced from the ventricles. So just by looking at the width of the QRS, we won't be able to say that it's a complete heart block. What we have to see, what we have to show is the P waves occurring at a faster rate and the QRS occurring independent. There's no correlation between the P and the QRS on the ECG. Now we come to idioventricular rhythm. This is the condition where all other secondary pacemakers have stopped functioning. And as I said earlier, the ventricles are the last step in the hierarchy of the secondary pacemakers. And usually we see this sort of picture when a patient has had cardiac arrest or is terminally ill and CPR is going on, and we see sometimes that this is the only rhythm that is seen on the monitor. So what we see here is broad QRS complexes, there's absent P waves, heart rate is usually less than 40, and sometimes we have a condition where accelerated idioventricular rhythm, where because of drugs or other reasons the heart rate could be faster. So this is a picture that we would see on a monitor. We would see broad QRS complexes with bradycardia and no P waves. So having seen the common patterns of bradycardia in an ECG, how do we approach an ECG with bradycardia in it? You're given an ECG which shows bradycardia. How would we approach it? As always, as with any ECG, we'd follow it by following the 12 steps: calibration, rhythm, rate, axis, P wave, PR interval, QRS complex, progression of the R wave, ST segment, T wave, QTC interval, and U wave. But with connection to bradycardia, there are certain steps we would pay a little more close attention to: the rhythm, the rate, the P wave, the PR interval, and the QRS complex. So these would be important in helping us to come to a diagnosis of the pattern of bradycardia in the ECG. Rhythm we see, is the rhythm regular? Now in sinus bradycardia, junctional escape rhythm, complete heart block, idioventricular rhythm, all these might have a regular pattern in the rhythm. Now you could have these ECGs which show irregularity in the form of pauses which are actually responsible for the slow heart rate. For example, sinus pause, second degree SA node block, second degree AV nodal block. Here you could have these long pauses in the ECG which would otherwise be irregular. Sometimes we have irregular ECGs like in wandering pacemaker, or it could be an atrial fibrillation with a very slow ventricular rate. We had covered atrial fibrillation when we did tachycardia, and so normally you have tachycardia because the ventricular rate is faster. But if there is poor conduction of the fibrillatory waves into the ventricle, you could have AF with a slow ventricular rate. So rate, bradycardia is definitely a heart rate less than 60. Sinus bradycardia is a very common cause, and most of the causes of sinus bradycardia are physiological, like people who are athletes, or people who are on who have a normal heart rate, farmers, active people, young people. And but if you have a heart rate less than 35 beats per minute, especially when they are exercising, it could be a clue that this low heart rate might not be physiological. We look at the P wave and the PR interval. If the P wave present with normal PR interval followed by every time by the QRS complex, that would tell you that this is sinus bradycardia, the commonest cause of bradycardia in an ECG. And usually these are don't need too much concern as some of the other causes of bradycardia. If you see P waves with varying morphology, it should alert you to wandering pacemakers. If you see P waves which are absent intermittently, it should alert you to sinus pause or sinus exit block, that is type 2. So as I mentioned earlier, in exit block, the pause between the RR intervals, the gap is double, which might not be the case in sinus pause, which is usually of a smaller gap. P waves, if they are consistently absent, that might be a feature that this is junctional rhythm or idioventricular rhythm. So if you have a complex of bradycardia and there's no P waves seen, it could be the junctional rhythm or it could be idioventricular rhythm. How do we differentiate both of these? It's by the QRS complex. In idioventricular rhythm, the QRS will be broad. In junctional, the QRS will be narrow. If the P wave is buried in the T wave, P waves buried in the T wave, it could be sinus rhythm with frequent PACs, and again sometimes in third degree AV block, some of the P waves might be buried in the T wave. So it's always important to look at the T wave also for any change in its pattern, like a notching of the T wave, which might actually be a P wave which is buried in it. We look for retrograde P waves just after the QRS complex on the ST segment. Sometimes we might see retrograde P waves, inverted P waves, and this can happen with junctional rhythms. And as I said earlier, if there's no correlation of the P wave and the QRS complex, and with the inconsistent PR intervals, this is a feature of third degree AV block. Coming to the QRS complex, what would be observed in an ECG in a QRS complex? First of all, is it a narrow QRS complex? Most of the conditions, sinus bradycardia, junctional rhythm, some of the third degree AV blocks can have a narrow QRS complex. Wide QRS complex would suggest you that this rhythm might be from ventricular in origin, like idioventricular rhythm. And as I said, some of the second degree and third degree AV blocks, if the ventricle is spaced from the ventricle and not from the AV nodes below the level of the block, the QRS can be wide. If there's an intermittent drop of the QRS complex, that would alert you to second degree AV block. If the QRS is not preceded every time by the P wave, it is a feature of third degree AV block. There is no correlation of the P wave and the QRS. That's a feature of third degree AV block. So in clinical practices, we talk about causes, and in ECG we talk about patterns, because there are different causes of bradycardia in clinical practice, but in ECG they manifest as patterns. For example, sinus bradycardia has different causes, physiological causes like athletes, during sleep, there can be bradycardia. There could be pathological causes like acute myocardial infarction, use of drugs, beta blockers, diltiazem, amiodarone, digoxin. They could all cause sinus bradycardia. Endocrine causes like hypothyroidism could be a cause of bradycardia. Sinus node dysfunction. Sick sinus syndrome is a condition which is a collection of different disorders which affect the SA node, where they could be an age-related degeneration of the SA node, could be some inflammatory process which scars the SA node, could be a cardiac surgery where the SA node might be damaged, and they are all grouped under sick sinus syndrome. And various drugs like lithium, digoxin. So these are conditions, obstructive sleep apnea, which could lead to sinus node dysfunction, and which manifest as either sinus pause or sinus exit block on the ECG. Junctional rhythm. So any condition or drug that excessively slows down the SA node, it requires a secondary pacemaker to come into action, and very frequently the AV junction steps in. And so sinus node dysfunction, drugs, digoxin, post myocardial infarction, sick sinus syndrome, all these conditions could result in junctional rhythm. AV block, second degree and third degree AV block could be either congenital, or you could have acquired causes like inferior wall MI, or degeneration of the conduction system of the AV node, or AV node blocking drugs, beta blockers, again verapamil, diltiazem, adenosine, digitalis, amiodarone, or again post cardiac surgery. So all these causes could cause a damage to the AV node, resulting in the pattern of AV block 2nd degree and 3rd degree on the ECG. So just to summarize, sinus bradycardia is the most common cause that we would see, either physiological or pathological, the pattern on the ECG. And there are two basic mechanisms of bradycardia. It's either due to abnormal impulse generation. The SA node is dysfunctional, it's not able to generate impulses, or it could be a problem with conduction. There's some way along the conduction system, there is a dysfunction in the conduction being passed on, transmitted. Then we talked about secondary pacemakers, how when one pacemaker fails, the next level in the hierarchy comes into action. And we saw the pacemaker in action results in the ECG pattern. If the atria, different areas in the atria act as pacemaker, we have the wandering pacemaker pattern on the ECG. If the AV junction acts as pacemaker, we have the junctional escape rhythm. If it's only the ventricle which is generating impulses, we have idioventricular rhythm. And we had seen that blockage of transmission of impulses can occur either at the SA node or at the AV node. In the SA node, we saw there was exit block, and that there were 3 levels of exit block. And similarly in the AV node, we have 3 levels of block, but 2nd degree and 3rd degree AV block are the ones which usually cause bradycardia. Now we're going to do 2 trial ECGs, and this is the first ECG. You could pause the video and just observe and try your hand at doing this ECG. So if you were to observe this ECG, you would almost immediately note that the P waves which you see appear to be all over the place. They seem to be appearing regularly on their own, but sometimes they are see, the 4th one is embedded in the T wave, and the 6th one is there in the QRS complex. So they appear to be all over the place on the ECG. And if you look at the QRS complex, they seem to be coming independent of the P waves. They seem to be having a rate of their own. So if you were to take a paper and mark the P waves and move that, you'd see that this is how we see that yes, there's definitely the P waves, they're coming regularly, but the QRS is coming independent of the P waves. So P waves seen, they're all over the place. There's no consistent PR interval. There's no fixed relationship between the P wave and the QRS complex. So the impression is this is a 3rd degree AV block. Now in the second ECG, you could pause and have a look and try this ECG. So here we see that the first 2 complexes, there's a P wave and you have a QRS coming after that. They seem to be correlating. And when you come to the 3rd and 4th complex, you see that there is no P wave before the QRS. Rather, you see that there's inverted retrograde P waves coming after the QRS. And if you remember, this pattern was commonly what I refer to as the junctional rhythm. So the first 2 look to be sinus rhythm, and the second 2 look to be as junctional. So what we notice that in the first, there is definite significant bradycardia after the first complex. Probably what has happened is this bradycardia, sinus bradycardia, has become so severe that the junctional AV junction had to step in as a secondary pacemaker. So after the first 2 complexes, because of prolonged bradycardia, the junction, AV junction, steps in as pacemaker, and it steps in as pacemaker and it sends impulses backwards into the atria, which causes the retrograde P waves in complexes 3 and 4. So the first two complexes show normal P waves followed by normal QRS complex. The only abnormality seen there is bradycardia. But the third and fourth complexes show no normal P wave, but there are retrograde P waves after the QRS. So this is sinus bradycardia, that is the first two complexes, with junctional escape rhythm, that is complex number 3 and 4. I hope you have gained some confidence in the approach to bradycardia in an ECG. I hope you'll be able to identify the different types of heart block in an ECG and be able to differentiate it from sinus bradycardia. If you're interested in seeing more videos like this, please do subscribe to the channel, hit the like button and the notification bell. Until the next time, bye-bye.